All right, once we're done with the KWL, I just want to go over our kind of plan for today. We're going to do one Menti. We're going to do a short break, probably only about 5 minutes or so, because there's so much content in musculoskeletal and connective tissue. I want to make sure we're able to cover all of it. We have a second Menti, and then we have a medication activity after that, because like you guys are learning pharm, you can't learn all of the medications in one class, right? We've got to go over medications as we're talking about different systems, so you can help get used to them, understand them. We're going to finish our KWL, and then our group project is coming up in a couple of weeks. And so I want to go over that with you guys too, so you have a good idea and understanding of how to prepare and start working on the group project now. All right, so if you haven't already, go ahead and log into the Menti. You can either scan the QR code or again, go to the menti.com and put in that code. Put this guy in. And if you've logged into the Menti, go ahead and give me a reaction. Let me know you're in. Ooh, I like the different color hearts. I'll wait for just a minute, make sure everybody gets in. While everybody is kind of logging in, getting set, scale of 1 to 10 with 0 fingers up being terrible, I am not ready for today and the test and the world. And 10 is I'm ready to conquer everything. I'm going to rock this test that's later today. I feel prepared for class today. Where are we at for kind of this moment here? So some variety here. We've got some range. All right, that's all right. It kind of gives me an idea of where you guys are feeling as a class, and hopefully we'll be able to engage fully in this. And then we're going to move on, and you guys are going to do really well on your test. Don't forget to do your super squats and power poses before the test later. I'll remind you before class ends. All right, so chapter 45 was musculoskeletal and connective tissue disorders. One thing I don't know in the assigned reading, hey guys, grab a KWL form in the name sheet. Chapter 44 was the kind of introduction to the musculoskeletal system. And so I don't know how long it's been since you took A&P. I don't know where you took anatomy and physiology. A lot of people took it online, which sometimes it's harder to connect with the material. So if you guys feel a little bit shaky with some of your anatomy, physiology, just remembering the systems, I really encourage you for those chapters, like chapter 44, that's kind of giving you an introduction and telling you about the musculoskeletal system. Look at those, read those, make sure you understand those, because that's going to really help you understand the contents when we talk about the pathophysiology or the disorders of the systems. Oh, I wrote it up here. Okay. Can you read this? 163904112. I kind of lost track of my space. So if you're just getting here, go ahead and join in on the Menti. So bone and soft tissue disorders. I want to talk just a little bit about, because you guys filled out the terms, and so kind of you're able to fill out some of these things. What's the big difference between a strain and a sprain?
Strain is like a muscle that's been stretched too much.
I think Carolyn had it back. What was it? And the sprain is ligament. Twisting. So the T, is it the T with tendons? Yeah. That's how I help remember is this strain with the T, strain is also, it's like involving the tendons, right?
Yeah.
Like that helps me remember it. Dislocation, where can we get dislocated at?
Shoulders.
Any of our joints, right? Common for shoulders, hips. We can also have elbow dislocation as well, or knee dislocation. Do you want to ask Amanda about her experience with knee dislocation this year? That was very fun. It was so fun. It was an experience. But when you have a dislocation, when that joint is made to function in a very specific way. And when that joint can't function in that way, it's incredibly painful. Bursitis, you can get irritation of the bursa, that's kind of a back inside the joint. That can get very painful for patients. Also rotator cuff injury is another common injury people see. Where's rotator cuff? Where's it at? Yeah, in our shoulder. Where do we often, what kind of patients do we often see with this type of injury?
Sports.
A lot of sports, baseball, I think like our pitchers or people who are throwing a lot. Also people who, depending on their job, right? If they're in construction or some sort of hard manual labor and they're doing a lot of different motions with their shoulders, that wears down that rotator cuff and that can really be painful. All right. You know, if you're doing proper lifting technique, I don't think you would be at risk because lifting technique, you should have your feet underneath you. You should kind of bend your knees. You're having your arms kind of down and you're moving together. That's not moving a lot of that shoulder. So I wouldn't think that would be a risk. Yeah, usually it's protecting your back. So on here, this is a lot of what we do for these strains, sprains, irritation, shoulder injuries. We use the RICE therapy for people. So go ahead and enter in, what does RICE stand for? One word, you can enter in 4 different times. So enter once for what does R stand for, once for what the I stands for, C, and then E. You guys are looking pretty good. I like the rest. You guys need to rest. So yes, you guys got this. Very good job, right? So we rest. What does rest mean?
You rest.
Don't be on it, right? Like you gotta walk to the bathroom or do things, but we don't want people to be up and moving around a lot. I think especially like ankle injuries, right? We're gonna use that as our example. I is ice. How often do we ice for? Rule of thumb is 20 minutes, no more than that every hour, you know? A lot of times people will say every couple hours, do 20 minutes at a time, but really you don't want more than 20 minutes per hour. And we'll go into that in a little bit. Elevate, how high?
Above the heart.
Above the level of the heart, which is this, if it's your ankle, how do you do that?
Lay down.
Yeah, you get pillows, you get something, you get the above the level of the heart. And then how do we compress? Yeah, usually a wrap, like ace bandage, those are perfect for wrapping. All right, so rest it to protect it, ice it, helps to decrease the pain, decreases that swelling, the inflammation that's there. Compress with the elastic bandage and then affect it if it's appropriate, which is really nice to say, like your shoulder, right? If you hurt your shoulder, is there a great way of elevating it really? Not so much, right? Our shoulders already generally pretty elevated anyway. So that wouldn't be appropriate for that. But your hand, your wrist, your knee, those are all good ones. So another question, a patient is seen with a left ankle pain. A sprain is diagnosed. The patient calls back later to ask how long the ice is to be applied on the ankle. I know I really shouldn't have just said that earlier and gave you guys the answer. I forget what I asked in the question. It's okay. I can see who's listening, right? So yeah, no more than 20 minutes at a time. I know a lot of people have like cooling pads or like ice pads, and those aren't bad. They want to keep them on all the time. I'm hesitant with those because that causes so much coolness to the area. I don't know how well it's regulated. There have been people who over ice and can potentially get frostbite, right? You can actually damage the skin because you want to, because what is the ice, what does it do to our blood vessels? It constricts them, right? It's helping to push away extra fluid, especially the elevated. If we don't give that tissue time to warm back up, and time for those blood vessels to kind of expand again, we're not going to have very good blood flow through there. We want to give time for those blood vessels to get back up and normal size running through before we put ice on it again. I think 4 times a day, that's all right. If I'm taking care of people, who have injuries, I'm usually every 1 to 2 hours putting ice on there, but only for 20 minutes at a time.
Do you do the ice and heat thing?
It depends on the injury.
Right.
Typically, like if we're looking at a post-surgical pain, usually just ice. And if somebody has like a muscle, like a back injury or something, usually they recommend like a moist heat. Like, I don't know if you guys talked about it in foundations yet. When we talked about moist, uh, I like to make, socks, old socks, and I put rice in them.
I know.
And then you heat it up in the microwave and it has a little bit of moisture to it. And that's the type of heat that can really be beneficial. Where if you have just a straight heating pad, that can help, but really having some moisture with the heat. So like, think about baths, right? It's really those types of like having the moisture in there helps. Okay, so next question. A nurse educates a nursing assistant to use which of these for patients to provide safe patient movement? So looking through all of these, you can hopefully select more than one. All right, and good job. All of these are correct except for lift patients' arms to reposition. I think what that means, if somebody's supine in bed, we really don't want to grab underneath their arm to kind of pull them up in there, right? That's probably going to injure or have potential to injure. We do want to make sure everybody has non-skid footwear on. Sitting at the bedside before standing, I think about my patients with orthostatic hypotension or just need to like get their bearings a little bit before they get up. A lift device is always good. Lift sheet. So that's just having some sort of usually big flat sheet under like kind of folded underneath the patient used to kind of move them up in bed. And then a walking belt or a gait belt is another term for that. Those are really helpful in keeping patients safe. So slide with heading. This is supposed to say carpal tunnel syndrome. This weekend I was working on this slideshow and I messed up a little bit. Okay, I pulled this off of the internet because your book didn't have a great description, but carpal tunnel syndrome is a really common disorder, especially seen in like tech workers, people who overuse. I just wanted you to kind of understand what it means. So here, this is your normal carpal tunnel. What it means by carpal tunnel is you have this bundle of nerves and ligaments and things that go right here through your wrist. And then you have this carpal ligament piece that goes over here. And if you get kind of this area inflamed, it all gets kind of trapped underneath this ligament. As it gets trapped, it gets irritated. And what are some of the signs and symptoms we see with people who have carpal tunnel disorder? Pain, numbness, tingling, a lot of issues. And so I kind of like this picture because it kind of shows right where those nerves and ligaments are at. So that medium nerve, that's the one that really gets compressed and is causing the issues. To relieve it, like how do we help take care of it? A lot of times they say splinting it. Sometimes the position that your hands are in. A lot of times we're like this or this. So the splint, it's just going to be a regular wrist splint. And so it's going to hold your hand in a nice neutral position. We also want to do some anti-inflammatories. You might even have surgery because what they'll do is they go back and they actually will make a little incision to release some of the pressure that's right here in this carpal tunnel. And when I say carpal tunnel, this area here, that's the carpal tunnel. It's not like a real tunnel that's in your arm. It's just kind of that space that puts all of those things in there. We also want to teach prevention to our patients. So what are some ways we can help prevent carpal tunnel?
Position, how you position if you're working. and stuff.
Yeah. Like you guys seen the keyboards that have like little bumps and things to kind of help your arms in a good position? I think about our occupational people who like work, in fact, if you have repetitive motions, right? What did I do? When I was in high school, I worked at Sonic and we would have to squeeze our own lines. And so I remember if I opened at the store, I would have to squeeze lines like for like an hour and I was just squeezing lines. And I was like, oh my gosh, this is horrible. And my wrist would hurt. And at the end of the day, I would just be like, oh man, that doesn't feel good. That was not a good thing to do for an hour at a time, right? Optimally, we probably should have all shared that task or, something. But we want to teach like, hey, if this is bothering you, if you notice a movement that's irritating, let's stop doing it, right? Let's figure out something else. Fractures. What's a fracture?
Right.
Yeah, it's a break in the bone. So there's a lot of different types of fractures. They can be caused by trauma, which is what usually we think of, right? We think about, what's the way you get a fracture? Yeah, we have our grandma who falls down and breaks her hip. When I say break your hip, I just want you guys all to know, usually when you say you break your hip, you have your pelvis and then you have your femur, that's that kind of ball and socket joint here. When you have a broken hip, it's usually the top of the femur that breaks, not necessarily the pelvis that breaks. That's good to know. But we also have pathological, which means from a disease process. We're going to talk about osteoporosis in a little bit when the bones get kind of porous and not as strong. So you can have times where those bones can compress and break because they're weakened. Closed fracture, it stays within, right? So if I'm looking at my arm, it might be broken. The bone, like the whole arm might be deformed, right? It's maybe bending here, but as long as there's no opening in the skin, that's a closed fracture. If this part of the arm is bending down and there's bone sticking out, that's an open fracture. Okay, so closed versus open really just means there's opening in the skin. Open fracture, that's going to be a big infection, right? Because anytime we have where pathogens can get inside of the arm there, we know that's going to be a higher risk of getting infected. I'm just going to briefly go over all of these types of fractures. This chart is in your book as well, but it's kind of good to know because depending on the type of fracture, that lets us know how it happened and it also kind of guides us in how we treat it. So avulsion, that's like where we have a piece of it kind of breaking off to the side, common in the knee. Commutated, that's kind of like a crush, right? So you can see where like in this, and these are all like femurs, most of them. So like in somebody's femur, something just falls and lands on it, it's going to crush that part there. Impacted, that's where usually you have a fall, somebody falls down and your bones took a lot of that weight, but it kind of broke it, kind of brought together. Green stick fracture, do you remember where, so this is when the bone kind of bends a little bit, and you can usually see a fracture just on the side. What population do we usually see this in? In kids, their bones are a little bit softer than adults, and they haven't fully formed totally yet. Because of that, their bones are able to bend. I mean, that's why kids are like almost unbreakable sometimes. Like the things that they do and they fall, and I just said, like, how do you live? They have these kind of bendy bones and stuff. And so you often can see just a fracture kind of on one side because the bone bends a little bit. Interarticular, kind of inside the joint, it can kind of, especially when it's right on top of that little joint sitting there. Displaced fracture, that's when you have it totally, like the bone has separated. It's not just like where the green stick or impacted, where it's kind of all to get the bone still together. The bone is totally offset. Pathologic fracture, oh man, I think that's where there's like it's an infection or
It's a
tumor, yeah, like there's something causing it where it's not necessarily trauma or anything, it's something pathologic, which is called pathologic, that's causing the bone to be displaced. Spiral fracture, that's where there's some sort of twisting motion that on the bone that actually you can see the fracture looks like it's going in a spiral, not a perfect one. When we see somebody with a spiral fracture, what are we concerned for? Yeah, abuse. Anytime you have somebody come in with a new spiral fracture, we're gonna be doing a safety and wellness check. Because if somebody, you know, if you grab somebody's arm, leg, whatever, and you twist it really hard, that can cause a fracture. Often we see this, especially in children, who are abused. And so, or just people in general. It can also be caused by other things, right? You get caught in a escalator at the mall and you're turning around and somehow you twist and get your leg broken. That could cause a spiral fracture. Either way, you generally just know a spiral fracture means we're going to do an abuse screening. So we want to make sure these people are safe if we're discharging them home. Longitudinal is going to be the break is kind of the lengthwise of the bone. Oblique, it's going across the bone. Those are kind of descriptors. Stress fracture, that's where you have like a lot of like stress, especially like I like they put our feet here because our feet take a pounding, right? Literally every day. And sometimes you can have a stress fracture from that. And then transverse fracture right across the bone, which oblique is kind of more tipped and transverse is like right in the middle or kind of straight. So anyway, I don't want to spend too much time on it, but I just want you to know like there are differences in types of breaks. They tell us maybe how the break happened and also how we're going to treat it. So with fractures, signs and symptoms, because you can see, especially with some of these fractures, we might not actually know if there is a fracture there just looking at it. Some of them probably, but most of them, we're going to be curious. So our signs and symptoms, they're going to have pain, right? It's going to hurt. We're also going to have decreased range of motion. You're not going to be able to move around that affected body part as easily. Limb rotation, what does that mean? The limb might be actually a little bit malrotated. We go back to our example of grandma who fell down and broke her femur. If I lay down, my legs are going to kind of look, I just shouldn't wear a skirt today. My legs are going to be kind of straight on, right? If I break my femur, some of that internal structure of what's kind of putting my legs together is broken. And so if it's my right leg that breaks, my limb is probably going to rotate out because it doesn't have the same structure. So as you're doing your assessment, grandma's like, I fell down, I hurt, it doesn't feel good, and one leg is kind of tipped out. That gives you a clue that there might be a break there. Also, deformity, right? It looks funny, or shortening of the limb. To go back to grandma, if I'm looking at her legs and one of them is noticeably shorter than the other, I'm going to be real worried that maybe, especially like a high femur fracture, like with her hip, that we've just kind of moved that bone up a little bit, right? And because that femur is that structure of the bone, that her leg is probably going to be a little bit shorter than the other leg, the affected one. So that's why when we're doing our assessments, we're looking at, you know, and sometimes I might say, are your legs usually the same length? You know, some people aren't necessarily built, you know, like the normal pattern. And so we just want to make sure, but that would be a sign. There's also going to be swelling and bruising, right? We've all had that happen to us. We get swollen and bruising. There we go. All right, so how do we tell if it's broken? Most commonly, they're going to do an x-ray. That's kind of one of the first line responses that they do, all right? Let's go get an x-ray. Just quick, it's easy, it's fairly inexpensive. Sometimes they might want to do a CT scan as well. It's going to give us a little better view overall of the patient's view. And have you guys talked about CT scans a little bit, how they work? So x-rays work by, they really look for bone and air and things like that. You can kind of see outlines of the hard things in the body. A CT scan is, oh gosh, that's going to mess up the thing. Use my water bottle. So in a CT scan, there's like a, let's pretend this is like a circle. This is a CT scanner. It's usually like a tube. It's not really a long tube like an MRI machine. CT scanners are like this wide and they have a big circle. And then the patient goes in and out, and they're scanning whichever part is appropriate. You know, if it's the leg we're looking at, if it's the head, whatever that is. This is the person. They go in and out of the CT scan. And what they're looking at is actually, and I don't know how, it's like magic, but they do little slices. And by doing that CT scan, they can go back and pull, like, okay, I'm looking at maybe this is grandma, and this is her like hip area. And they're gonna go, okay, I'm gonna look at the slice of this hip. And they can visually like pull that out and see, oh yeah, there's where the femur is. Oh, that kind of looks, something's going on. They'll go to the next slice and look there. So they can kind of see the whole inside, like it's a cross section of a person. Kind of help understand CTs a little bit. So that's how they're able to tell us something different than an X-ray, because they're actually, instead of just looking at the outside, they're looking at the inside, which again, it's magical. I don't even know how they do that. What's that?
Inside of the bones.
Yeah, I mean, everything, the whole body. It's like if somebody like took a sword and went and
Right.
another sword and then it pulled this piece out, and you would just see a
You see
cross
the
section of
layer.
all my intestines
Yeah.
and stomach and all the things. Like, it's not like in color, but it's very cool.
Yeah.
Okay, emergency treatment. So what do we do for somebody if we think they have a fracture, especially if it's displaced, grandma's leg is short and weird? We splint it as it lies. And what that means is don't go try to reset the bone or line it up, because we don't know what's going on inside. I think especially in our femur, what's another very important body structure that's going through here? Yeah. Yeah, we've got our femoral artery, right? And if we have a very sharp bone shard that's in there from the break, I don't want to move that around and potentially injure that femoral artery, because that can cause some damage, right? And we also want to get medical treatment if we're out in the world. If we're at long-term care or we're at an office where somebody falls and something happens, we're going to call 911, right? Because we don't have those medical teams there to fix that. We'd be outsourcing to somebody else. Therapeutic goals. So our goals, what we want to happen, we want those bone ends to get lined back up so they can fuse back together, and we want to keep it immobile so it can happen. All right, cue recognition. You find a patient on the floor after a fall. The leg is noticeably shorter and the pain is 8 out of 10. So turn to somebody next to you, and for 10 seconds, we're going to say, what would you do? All right, so what does F.A. Davis say? Splint the leg and call for help. I mean, honestly, depending where I was at, I mean, if I was out in the forest, maybe I'd do that first. I'd probably, if I was at a clinic or somewhere, I'd be like, and as I'm getting things ready. We want to make sure, like we said, to avoid further damage. You can use a towel or bed linens, something to just try to keep it nice and protected where it's not moving around a lot. A lot of patients, I mean, they'll tell you. I had a patient who, oh, still, I have like PTSD. I volunteer a lot with my church and our youth group. And so I'm always like the youth group nurse for trips that we go on. And I have had the privilege of taking care of lots of Natalie ones and where things happen. So years ago, we were at a winter camp, and one of the youth leaders, I'm thankful it was a leader. I mean, not thankful, but it wasn't a kid. And they went down this giant snow tube hill, and they were the first ones trying it out. And we didn't realize is that it had rained a little bit the night before. So there's this beautiful sheet with ice on top of the snow. So the ice made her go down very fast on the snow tube hill. It launched her off of the tube. Her leg landed, but because it had this nice thing of ice on top of the snow, it kind of trapped her leg there and then went further. And it broke her tibia, fibula in about 4 different places. I love it too. Oh, yeah. And so we were about 40 minutes from Leavenworth. So what did we do? We stabilized her. We carried her up the hill. We splinted it. Yeah. We got her into the back of a van. And I drove her, well, I didn't drive her, I had somebody else drive us to the ER. And the ER in Leavenworth is very tiny, by the way. So it was like had 2 rooms in it. Anyway, and they ended up having to stabilize her overnight and transporting her the next day to another larger facility because they weren't big enough to do the full surgery that she needed.
Yeah, for kids, you have to have like immediate surgery for tib fibs, right?
I mean, anybody, you should
Oh,
have
anybody.
pretty immediate
For
surgery.
any tib-
Yeah, just because, especially not knowing where those bones have lined up and all of the issues. The thing I was gonna say about this is that when bones rub together, what is that? What does it cause? There's a, it's sometimes you can feel it from the outside. It's called crepitus. And so for the whole ride, I was helping, like holding her leg and keeping it stable. And I could feel those bones just rubbing because they were just so broken. It was awful. Anyway, it was really funny because when we got there, she was a young volunteer in her early 20s, and she she had her Lululemon pants on and her hunter boots, and we had to cut off her pants. And she was like, "Don't cut off the hunter boots, they're my mom's."
Oh, no.
We didn't, we were able to get them off. I
Yeah.
mean, it was a near thing. But actually I left them on because that boot was helping to cause compression and stabilization, right? Because that swelling, that's what your body is naturally doing to that bone area. It's trying to stabilize it. It's saying, oh, something is wrong. I'm gonna swell up here to try to cause a little bit more stabilization to this area. Okay, that's my gnarly story about that. So here's the healing process. We talk about clot or break. So we have the break, and there's actually clotting, right? The bones are so vascular, so much blood flow. They cause a clot. All of these fibroblasts and osteoblasts come in, and they start healing it up. They cause this callus that forms, and this new bone forms in there, and eventually you have this totally healed, repaired bone that ends up being a little bit stronger than the rest of the area around it. Usually you won't see a break right where you had a break because the area is nice and strong now. Usually if you have another break around it, it's somewhere else on that bone. You will see usually a little bit of reformation, like where there's kind of a little bump here that probably wasn't there before because the body is saying, hey, there's injury. Whatever happened here, this was a weak point. I'm going to build it up so it doesn't happen again here. It's a kind of a protective mechanism that it forms kind of a stronger area. So how do we fix our fractures? So management of them, closed reduction. So this closed reduction, kind of like we have our open and closed fractures, that's where reduction is where we're like lining it back up, right? Grandma's leg is shorter than the other. We want to get that bone kind of leg pulled back where it should be. Unfortunately, with the hips, can't really do a manual realignment. You know, maybe with arms, we can try to get them lined back up where they should be. That's a little bit easier. We want to do, sometimes there's elastic splints or things, especially if it's like a green stick fracture, which is more of that bend. They might not need a full hard cast. They might just need some splinting to kind of let the bone heal. Sometimes they need a full hard heavy duty cast to go on to protect that bone and keep it aligned as it heals. They also sometimes have what's called traction. And I think I put a picture in here to show you guys. Yeah. So let's say they had a tib fib fracture and they're waiting to go to surgery. Okay. Those bones, we want to keep it kind of a lot like aligned, but because of the muscle, it wants to like pull those bones together. It causes so much pain, all that crepitus and the bones rubbing together. So what they do is they will attach, if it's a tib fib fracture, like this picture shows, they'll put like this wrap cast on somebody's foot to kind of stabilize, you know, this way where things are at. And then they have this, it's a traction device. They put weights on the end that attach here, and it gives a little bit of pulling to that leg to help keep those bones from rubbing against each other, keep them aligned. Okay, I don't see it a lot. Usually, I think you might see this in more rural hospitals where they can't take somebody right into surgery. But sometimes you will have some traction. There are also times when they put little pins in the bones and they'll attach the weights to those bones to help pull them and put them into the right place as well. Other types of, so if we can't do the closed reduction, right? Closed means closed skin, there's no openings. We'll do an open reduction. That means surgery. They have to open up, let's say if it's the arm here, they have to do an incision, align the bones, and then they can do internal fixation or external fixation. Fixation just means fixing it in place. So if it's internal fixation, they opened up the arm, they put some screws maybe to kind of put it together, fixed it and closed it up. External fixators are usually for when it's kind of a gnarly piece. My husband had one of these when we were in college. He was playing tag on a playground in the rain at night. There's a lot of bad decisions, like all through there, right? And so poor college kid, he went and I tried to jump from this playground to this other thing. It was plastic. He slipped, he landed on his forearm and shattered it. And so he had an external fixator, which means they went and did surgery where they opened it up. Plates and screws couldn't hold it together for just the inside. So you have these external like metal rods and things that help hold everything in place. That's how he showed up to college. I'm from the Midwest. That's where he showed up. This West Coast guy with weird hair and this giant contraption on his arm. We were like, who are you? He was having a basketball scholarship. I'm like, you are not playing this year. So the pins that are outside are kind of, they help, we have to make sure we care for the wound in a very special way. Here is a picture of an internal fixator, especially on a hip. Excuse me. And again, like I said, with hips, it's not this pelvic bone that is injured. It's usually the top of the femur. And so here they put some metal plates, screws. Look at this. I always call orthopedic doctors, the ones who fix these bones, they're like carpenters, right? They're hammering, they're screwing. It's a lot of work, and these patients are having a lot of pain. I work in peri-op, so like getting ready for surgery or taking care of patients in recovery room or after surgery, per diem still. And last week I had somebody, she was like, I got my hip surgery done. She goes, but my whole leg hurts. I'm like, yeah, you had your hip replaced. They took the bottom portion of your femur and they hammered this big thing into the femur and then fixed something else up into the ball joint and then connected that together. That's really painful, right? That's why there's anesthesia that puts you to sleep during, and we give you pain medicine after. It's very painful. Here's a tib-fib fracture where they had to come through. See how just crazy broken this is here? It wouldn't be enough just to set it and let it heal. There's not enough bone left. Let it heal right here. So they had to put these screws in to hopefully give that bone a chance to kind of come together. That's another internal fixation. Where's the external fixator? Okay, so here's a picture of external fixation. You can kind of see how they have the pins and screws outside of the body as well. And here's one in a real person. It was really hard to find a good picture of these. But you can see they have these big things sticking outside of them. What's something you would be concerned of for these patients? Infection, right? Because you have something outside that goes directly to the bone. We want to make sure we're doing really good skin care. And eventually, just so you guys know, these do come off, right? There's all the metal inside the body, and they're able to sit, once the bone heals, they take these off. With my husband, you know, our frontal lobes don't develop for a while. He went for a while with this big contraption on his arm. And because he moved to the Midwest, he didn't have an orthopedic doctor to see. And he finally found one because the skin was like growing up over the little bolts and screws. Oh, no. And he finally called his doctor who was here in the Northwest. And he said, I can't get a doctor to take care of me because all the doctors in Kansas were like, I didn't put this in. I don't know you. I don't want to take responsibility for whatever this is, right? So finally the orthopedic doc here was like, listen, you're at college. Do they have a shop? So we went to the shop and he got wrenches that were the right size and he took off the screws on all the places to take out his external fixator. I was blown away. That was the
No
nineties,
way.
so things I guess are just looser then. But I was like, that was so rich. But I mean, I do appreciate that the doctor was like, listen, you're really gonna have a bad issue if you keep that on, right? You can't keep that on forever. It needs to come off. Whew. My husband has very high pain tolerance. I don't know if I could have done that to myself without any anesthesia. I just hope he wiped it down. You know, I'm imagining there's like car grease and things on there. I don't know. Okay, so moving forward. If a nurse is caring for a patient with external fixation device, which of the following actions does a nurse implement? Select all that apply. What a varied response. All right, let's see. All right, so we don't necessarily want to avoid touching the pins themselves because you might have to kind of touch the upper pins. We maybe want to avoid touching like the screws, like where they go into the patient at. We do want to follow agency policy. If you ever see a question that says follow the policy, that's a test taking clue, right? That's saying, yes, you always as a nurse want to follow whatever the established policy is. Cleanse with hydrogen peroxide. Why don't we use hydrogen peroxide? Yeah, it can kill tissue. We usually want to use any kind of approved cleanser. Sometimes they'll even say soap and water. It just depends on wherever, like whatever is recommended where you work. Why don't we want to loosen the pins? We don't want it to fall apart, right? We want it to stay in place. We do want to monitor that pin care, like the pins every day. And we want to use strict aseptic technique, right? We're not going to be able to use sterile technique because those pins, especially if it's a leg, it's out there, it's everywhere. It's gonna have some things getting exposed to it, but we want to try to keep it as clean as possible. Okay, complications. So when we have fractures, what kind of complications can happen? Hemorrhage, right? Bleeding. We talked about femoral fractures right next to that femoral artery, right? That's a very big risk of happening. Acute compartment syndrome. We're going to talk about that in a minute. I have a picture. Neurovascular compromise, right? What does that mean? Those are all signs and symptoms of it, right? So if we have a lot of swelling, if we have structures that are displaced or moved around, it's going to press in on some of the nerves, blood vessels, whatnot. We're going to see some of these signs and symptoms. And if we don't fix whatever's going on, there can be damage to either the nerves or the blood vessels or the tissues beyond that point from not getting enough blood supply to that area. We're always worried about infection. Non-union. So union is bringing something together, right? Non-union means you bring the bone together, but it doesn't heal. It doesn't sit like it should, right? That could happen. And then thromboembolic complications. Let's do some word building. So thrombus, and embolic. So what is a thrombus? It's a blood clot. That's usually what a thrombus is referring to, a blood clot. And then what is it embolic or an embolus? It's usually something that's traveling in your blood system. So we can have different types of embolus. We'll talk about that a little bit later. But a thromboembolus is a blood clot that's traveling somewhere. Where are the three big places we worry about it traveling to? The lungs, the heart, and the brain, right? Any of those, lungs, heart, and brain, those can cause serious events, could even have a tissue death. Fat embolism syndrome. So when you have a fracture of your long bones, so the long bones, your femur, your humerus, yes, humerus. So funny. Any of your long bones, there's actually fat in them. And if you break those long bones, little pieces of that fat can escape and go into your bloodstream. Those could become a fat embolus, and then that could travel to your lungs, heart, or brain and cause very similar symptoms than a thromboembolus. When you have those symptoms of a thromboembolus, it's just saying that something's cutting off circulation, either to the lungs, heart, or the brain. So if somebody has a fracture of those long bones, we're going to make sure we're watching to make sure not only are we looking for blood clots that travel, but maybe if there's a fat embolism too. So compartment syndrome, this is just a general picture of your normal leg. When you have something that happens that causes a lot of swelling, you can see how the leg is getting bigger, right? But your leg, how much it stretches and moves, that's finite. It's only gonna go so much. And once it's moved out largely, as big as it will go, where does that pressure start pushing on? Internally, right? It can't push out this way anymore. So it starts pushing in on the muscles, the blood vessels, the nerves, all of that. Compartment syndrome is a serious potential side effect. And usually it has extreme pain, there's swelling. Oftentimes there's absent pulses distally. Like if I have compartment syndrome up here on my arm, I might not be able to feel my pulses here because it's pushing in so much on this area here. Blood is not able to get through. It's pushing in on the nerves. So you might have some nerve pain, some weird feelings. It's a serious event. And if you do have compartment syndrome, that needs to be addressed right away. A lot of times they might do a fasciotomy or something where they open up the tissue here to relieve some of that swelling so that blood flow can continue to go through, so that pressure on the nerves is lessened. Go ahead. One sec. What was the question first?
I was gonna say, can you like lose, can it be like so severe that you could like lose your limb?
Yeah. Yep.
Is the yellow part, is that representing like tissue?
Yeah, like fatty tissue, all of that around there. Yeah, and then it's just getting filled up with fluid and whatnot and swelling. Good question. Thank you, guys. All right, so the nurse is collecting data on a patient with a left tibia fracture. Which of the following is a priority finding? All right, you guys are amazing. Yes, if your pulse is absent distally or farther beyond where the injury is at, that's going to be a priority finding for us. So we talk about nursing diagnosis, like when we start doing concept maps, right? And so acute pain, impaired physical mobility, risk for neurovascular dysfunction, those are all really good nursing diagnoses with people that have musculoskeletal issues. So some of our nursing care, we're going to do those neurovascular checks you guys learned in lab. We're going to make sure we've got CSM checks, cap refill, pulses. We're going to go through all of that. We're going to look about pain management, taking care of a cast if they have it. One thing, I think it shows it here. This is palming a wet cast. When a cast is first put on, it's a little bit wet, it has to dry, and as it dries, it hardens. You don't want to grab a cast and then have like your finger indents in there, kind of smoosh it a little bit. So you palm a wet cast. You kind of just gently lift and move while it's still wet. Going back to here, we'll talk about skin care, right? Especially if they have external fixators, we'll be doing the skin care around there. If somebody has a wound, maybe they did an internal fixation, we're going to do dressing changes on there. You guys are doing dressing changes in lab right now, right? Yeah, it's really important. We're going to talk about good nutrition. What are some of the nutrition pieces we really want to encourage people when they have had a fracture? Yeah, a lot of protein, good vitamins, things like that, all the stuff they need to kind of rebuild. Self-care deficits. If somebody has that external fixator, they're going to be able to probably work. Depending what they do, very likely not. 1 second, Kelsey.
cast or is that the down?
The providers will, yeah, the nurses will assist.
I was just about to say, I cast.
Oh, you do?
Yeah.
Like by
Not
yourself?
cast. Yeah, I just did the wedding and I do it at work.
Oh,
Yeah, I cast, not cat, I split, is it split? I use
yeah,
4x35, I use the wrap,
yeah,
yeah, I harden it and then I put ace wrap around it.
all around it.
Yeah, we make them.
Amazing.
Yeah,
That is very cool. I did not realize that.
yeah, not like, we don't do the hard cast though. We
Oh.
do we do the split, I think split, yes.
Yes.
Yeah,
Okay,
but not the hard. I think, yeah. the
yeah.
hard- Yes, the hard.
Occasionally. Yes. They still do. It's not all the time, but you will still see them. In fact, I thought I had another picture somewhere here. Huh. Anyway, there's a picture of bivalving the cast and like, anyway, you might have to, like in surgery, it was a year ago, there's a patient came in with a hard cast and we had to remove it before she went into surgery, right? And so that's the provider. They have this like little saw thing and they go through and remove the cast. The question?
Yeah, question. When you break a bone, do you want to automatically just take calcium just because like it'll help with the healing?
mean, I would.
process? Just.
Yeah, I
just
think
with anyone who breaks a bone, just like, oh.
unless you have a disorder or a kidney issue, something where you might, yeah, I would just take calcium.
Yeah.
Yeah. Let's see. So the nurse is collecting data on a resident who fell. Which data would alert the nurse to a possible hip fracture? Select all that apply. I like that we have some varied answers here. All right, so let's talk about this. So yes, deformity, it might look different. Groin pain, for sure. Increased range of motion, it's gonna be decreased range of motion. They're not gonna be able to move that area as much. Limb rotation, yeah, remember that structure is not gonna be in there as much and it might be rotated, usually externally, maybe internally though. And then lengthening of the limb. It's usually gonna be a shortening. So, yeah, not usually lengthening of it. It's shortening, especially those long bones, because the bones, now that they can't stretch those muscles out, they're kind of, it's pushed. Yeah, the muscles are like pulling the bones, like they're trying to pull.
Like, he was like.
Oh, like the bone was like, "Pew." Yeah.
Kind of pull.
Yeah, usually, because if you think about the leg, you have these, like in the femur, you've got this nice femur and you have these muscles that are real strong. Your thigh muscles are super strong. And so if a femur breaks, especially if it's displaced, the muscles are trying to pull it together, but they're not able to realign it. So it has a little bit of a shortening effect to it. All right, let's keep going. I'm going to get you guys to your short break. Osteomyelitis. So word building. What is osteo? Bone. What's myelitis or itis?
Well, I just said infection in.
Yeah, infection, right? It's an infection of the bone. So here you can see where somebody can have like a little infection that starts, blood flow gets impaired, and eventually you can have all this stuff and pus that can leak out into the surrounding tissues. Gnarly. Usually, we don't see the bone, but we can see the tissues around the bone. Those are going to be swollen, red, painful. Usually you have to do a debridement, which means you have to open up that area surgically and clean that out. They're going to do antibiotics. They might do some reconstruction, meaning kind of putting more, sometimes they can do bone grafts and things, trying to heal it up. Palliative therapy, meaning if somebody has a chronic infection of the bone, I think about our diabetic patients, they've got really slower response to healing. Sometimes their infections are just gnarly and they have to have some amputations, but maybe there's chronic infection. We might just be like, okay, let's just get rid of this part of the bone. Let's see if we can salvage the rest of the foot. That we're going to be So that's what I mean by palliative, is that we might not be able to cure this, we're trying to like suppress it, keep it at bay as much.
Well, I was just gonna say, cause, for pharmacology,
Yeah.
we're learning how to drugs,
Yeah, yeah.
that's the same thing.
So
I know it's
palliative
different.
just means any time that you have a disease that's not gonna be cured. There's curative therapy and palliative therapy. And then sometimes we also talk about like,
So like with this,
I think we're almost thinking in different terms. So curative therapy might be like an antibiotic
right,
in a
right.
sense, where we might say you have, you know, tuberculosis and we're gonna give you this infection. Or, yeah, I don't know. You have strep throat, or you have
Yeah,
strep throat, we're
yeah.
gonna give you erythromycin.
Yes.
That's gonna cure. That's a curative therapy. We're gonna cure the strep throat. Somebody who has a chronic disease, I would think even people like diabetics who need insulin, right? We're giving them insulin not to cure their disease, but it's just a replacement to help that disease process.
They can't cure.
Right, you can be cured from it. We're just giving it to help that disease process. Now, when we talk about
And-
pharmacology, I think sometimes we talk about palliative care drugs, meaning people who are close to end of life. And so that's a different thought process. So sometimes we use palliative care a little bit differently. So have you guys heard of hospice care? So hospice care is usually somebody who's going to be passing away within the next year. Palliative care is anybody who is probably going to eventually pass away from this disease. That's different than palliative therapy, really. So that there's a little bit different how we're using the terms. Palliative therapy might be like, hey, we have, it could even be like pain management, right? Somebody who has chronic cancer that's metastasized to the bone, it's very painful. We're going to give them a lot of pain management, not because it's going to help them, it's going to like cure, it's going to help them keep living their life the best they can. People who have CHF, congestive heart failure, we're going to be giving them a lot of diuretics and other things to help them feel better, help them function the best they can. But we do know that's probably going to be what does end their life eventually. They're probably going to die from complications from those diseases. That got really dark.
Sorry.
So, but it's a good question because we do use the word palliative
Right.
in some different ways in the medical field. Non-responsive, if people aren't responsive to treatment, amputation, you gotta take that bone off. So with osteomyelitis, prevention is the key, right? If we can prevent something from becoming infected, that's the best way. Usually infections are caused by something, either trauma that happens, if they have a surgery. I think about those patients that have external or internal fixators, right? There's a big potential for having infection and on the bone there. We want to teach them about medications, right? Especially antibiotics. What do we teach them about antibiotics?
Take it every day, that's prescribed.
Take it until the whole thing's finished, not just till you feel better.
You have side effects though.
Yeah. I don't want to go through this. Osteoporosis. So word building again, osteobone, porosis, porous, right? The bone starts, calcium gets leached from the bone. We're pulling it out to use the rest of our system, leaving the bone with little holes in it.
Yeah.
So it's not as strong. So most common, you're going to see fractures in the spine, wrist, and hip, but all bones are affected. And when it says imbalanced remodeling process, normally your bones are going to heal up in a fairly, normal fashion. It might not heal the same one side, one part versus the other part because they don't maybe have all the nutrition or they have this disease process. Women are more common than men. We have these healthy people 2030 goals in our nation. And one of them is to increase the proportion of older adults who get screened for osteoporosis, just like we do blood pressure screenings for people as they get older. We want to screen people for osteoporosis. Typically they're women. Somewhere, yeah. So I'll go back. If you have your hip or vertebral fracture, you do have a big decreased quality of life because of the pain, the discomfort. And also there's about during the year after you have a hip fracture, you are at greater risk of dying from all the complications resulting from the hip fracture, right? You're not going to be as mobile. You might not be breathing as well. You might develop pneumonia. You might develop a blood clot. You might have any number of other things that happen. But you do have a higher risk of dying after that. So we really want to make sure we can prevent those events like having a hip fracture from happening. So non-modifiable risk factors. So with osteoporosis, as you get older, you're more at risk. If you're a woman, you're at higher risk. If you have family history, usually it's typically your small boned, petite body build, usually white or Asian ladies. So when I've got little white thin grandma, I'm like, oh, tell me about your calcium. Like, what are we doing here? Because they're at high risk of having osteoporosis. Also post-menopausal, if you've gone through menopause, our body doesn't absorb calcium the same as it did when we were younger. And so we are higher risk for osteoporosis. So tell me, what are some non-modified, or what are pardon me, those were non-modifiable risk factors. Tell me what are some modifiable risk factors for osteoporosis?
How do you screen for osteoporosis?
Usually they'll do some bone density tests, and that's able to tell them the density will be very low because that calcium has been leached out. All right, hear a lot about lifestyle, calcium intake, nutrition. What about, is genetics a modifiable risk factor? Right, because we can't change. Modifiable is something we can change. Unfortunately, we can't always change who our family is, right? We're kind of stuck with the genetic lottery that we got. Exercise, vitamin D intake. Oh, I love this. Yes, smoking, right? Smoking is a big risk factor for osteoporosis. We're going to teach them don't smoke. We also have alcohol use. That's a risk factor for osteoporosis. If you do excessive protein, caffeine, or sodium, and then also a sedentary lifestyle. Remember, we're always encouraging our patients to be up, be active, be moving. That's going to help contribute to keeping strong and healthy bones. Prevention, really, if you're under 30, please keep your healthy bone, like keep building towards a healthy bone. After 30, you're kind of done building the bone. We're just now trying to keep it intact. We're trying to maintain. So maintain your calcium and vitamin D. Why do we always make sure we add vitamin D? Yeah, you can eat all the calcium you want, but if you don't have vitamin D intake as well, your body can't absorb the calcium. How do our bodies normally make vitamin D? Right? When our skin is exposed to the sun, our bodies make vitamin D. So thinking about where we live, are we making a lot of vitamin D? Most people in the Northwest should probably be taking a vitamin D supplement because we're just not exposed to the sun enough to make healthy amounts of it. So most likely calcium supplements are usually paired with vitamin D, just to make sure you can absorb it. Weight-bearing exercises, and then avoid alcohol and smoking. Therapeutic interventions, we just talked about that. There are some medications that we're going to talk about in a little bit. I'm going to kind of pass over these because we'll cover them when we do our medication activity. We talked about this. Okay, the nurse would evaluate a 60-year-old patient as requiring further education if the patient states which of these to prevent osteoporosis. So before you answer, let's do some test taking strategy. If the nurse said, or if the question says, the patient's evaluated as requiring further education, does that mean the patient is saying something true that's correct, or they're saying something that's not true? Right, it's a not true statement. So they're saying they need further education. So it's which of these statements would we not recommend for osteoporosis or prevent osteoporosis? A little bit of variation here. All right. One person caught the calcium. So this is, I consume 1,000 milligrams daily of calcium. How much do we really recommend? After age, I think it's 55 to 60, I believe it's 1,200 milligrams of calcium. Below 60, it is 1,000 milligrams. But once you hit that age, we actually increase the amount of calcium that we recommend for people. They need more than just the standard.
So that's.
Right, because if they say I consume 1,000 milligrams of calcium, that's good, but it's not, it's not true, it's not a true statement because they need more than that once they hit 60. Paget's disease, and I don't know if I'm saying it right, it might be Paget's, I'm not sure. So it's a rare, non-curable bone disease. Usually you have very weak bones. They have a lot of breaks. It's super painful. It's a genetic condition. And so with these people, there's not a cure for it. So with them, we're teaching them, how do we try to stay safe? How do we keep you from breaking these bones? How do we try to help with pain and your quality of life? I don't want to go super in depth. I just want you guys to be able to remember that there is this disease. You might see it someday and go, oh yeah, this person has this disease. I kind of remember that. Bone cancer. So primary malignant tumors, what that means is primary and secondary cancers, and you guys are going to have cancers more in third MedSurg 3. Primary cancer means it started here. This is the primary source. Secondary is like, oh gosh, what's that word? I'm blanking on it. Malignant, or not malignant, sorry. I'm so sorry, I cannot remember what it's called. It's where it travels to another area. Metastasize. Thank you. Oh Lord. Oh goodness. I don't know what I did. Okay, let's just turn this off. So just so you guys know, bone cancers are typically seen in kids. We don't usually see primary bone cancers in adults. It's usually like Ewing sarcoma and a couple other ones that I had on those. Those are the typical ones you're going to see. Now you will see bone cancer in adults, but it's usually a secondary cancer. It's metastasized from somewhere else. I think it's like lungs and now I'm all mixed up for my slides. But usually in adults, if they have bone cancer, it's from somewhere else. You want to make sure if they found a bone cancer, we're helping them find the resources so that we've either, if we haven't already found where their primary source of bone is or cancer, we're helping to help find that and care for it.
Back to the osteoporosis. Is it, once you have it, is it treatable?
There are treatments for it. And so in the medication activity, we're going to go over some of them because what we can do is we can help, we have medications that can help prevent the calcium from leaching out. We also have some medications that can help build up bone a little bit more. And then a lot of it's prevention too, of just giving a lot of calcium, vitamin D, things like that. But there are some treatments for that. All right, you guys ready for a short break? Yeah, okay, I'm gonna keep it fairly short just because I really want to finish the rest of the activity. Let's come back by 15 after. I'm gonna get started then. If you need to take a little bit longer, that's fine. Just know I'm gonna start the Menti at 15 after. There's some treats on the back table if you need something to wake you up. I'm gonna figure out how to get out of this crazy Menti. Yeah. Different styles of teaching.
You're like, oh, sorry.
Chuchi and I are good yin and yang to each other. Yeah. We were following each other home from work yesterday. We both left here at the same time, and I was like, "Are you?" Actually, she wasn't, and I felt bad. She asked me to pick up something for her, and I already left. My son called me yesterday. It was like, "Where's the laundry soap?" And I was like, "It's where it's always at." He's like, "We're out." I was like, "How are we out of laundry soap?" Anyway, so I was really thankful he called me so I could swing it against it. Always right. I mean, to be fair, he was looking there.
Yeah.
And when I got home later, there was a container of dishwashing tablets on the washer. And I think he was considering using them. So I was really glad he chose not to do that. He's like 17, you never know like what's happening, like. Oh, I need to pause the Zoom. I'm sorry, people watching from home.